UEG Talks, Gastroenterology to Go. Welcome to our GI podcast. Listen for fresh insights and perspectives in science, education, and professional development.
Hi, Ian.
Hello.
How are you doing? How are you enjoying the UEG week?
It's been good.
What have you enjoyed the most? Have you seen something that blew your mind that will change your practice?
No, I wouldn't go that far. But what I did enjoy is I was involved with the gastroenterologist surgeon, the collaboration, which I thought was really good. I did it last year, and I did it again this year with Stella, and I never know how to pronounce her last name, who's an upper GI surgeon from Lausanne, Switzerland. So we do this thing about upper GI cancer, esophageal cancer. And it's really good because it tries to teach gastroenterologists or endoscopists what they really should be thinking about when they encounter upper GI tract tumors, what the surgeons are thinking about, how to better collaborate with our surgical colleagues, the whole importance of multidisciplinary tumor boards. So I think it's really, really helpful, especially to younger gastroenterologists and younger endoscopists. One of the other highlights, which I really liked, of course, was the 3 hours of live endoscopy that ESGE puts on. This year, we did it from the AMC in Amsterdam. Great cases. And the room was absolutely packed. People were standing on the back wall. And it's always well done. It's very well done. And I think it's a real teaching opportunity or learning opportunity for everybody who attends UEG, whether they're interested in basic endoscopy or more advanced endoscopy.
Yeah, there's something for everyone at each conference, or no matter your level. So could you identify some trends in endoscopy? Where are we going? Of course, there's AI things that are booming.
So AI is booming. I think that we're just at the beginning of what we really understand about AI, of how that's going to help us. I think it's going to get to the point where potentially it's even going to direct us in terms of what may be the appropriate therapies to provide. But just detecting polyps at this point is very simplistic. We need to have characterization of these polyps, size of the polyps, and those things are coming in AI. The other areas within AI that I think are going to advance is just the evaluation and management of Barrett's esophagus, IBD.
Early neoplasia detection.
Exactly. That's exactly right. Are we headed towards things like robotic endoscopy?
Please no.
Well, I think we're going to probably see it, but I think it's going to come down to a number of things such as cost issues, and it's going to need a demonstration that it's clearly beneficial than one of us holding the scope.
Yeah, so it's like in ORs with the surgeons. For Whipple's, in some cases it is, but...
Correct. But, is it relevant for things such as ESD or third space endoscopy? I don't know. And the other thing, well, there's a few other things. I think we're going to see more and more therapeutic endoscopy. And I think that's going to impact in terms of career choices for endoscopists. There'll be those who want to do really limited to more diagnostic type procedures, and there are going to be those who are really focused on interventional endoscopy. I mean, we're taking a lot of surgeries away from general surgery.
That's what I wanted to ask. Do you see the trend that we're becoming half surgeons?
We are.
In a way?
Yeah, we are, which I think is good because it's really minimally invasive. And I can tell you at my institution, a lot of things that we're doing today, the surgeons are very happy that we're doing them. Gastrojejunostomies, things such as POEM for achalasia, that yes, they're losing procedures, but they're also realizing that, at least if you look at the evidence, we're as good as, if not better, and especially with less adverse events in many of these procedures. And the other area that we're going to see with an endoscopy is there's going to be an increasing number of women who are going to be leaders in endoscopy. And we fully support that at the ESGE with our Diversity, Equity, and Inclusion Committee. And I think that's a good thing. And I think there are now a number of role models within Europe of women who are in interventional endoscopy, and that's going to attract more and more women. And there's a lot of patients who want their endoscopist to be a woman.
Why?
Because I think there are gender issues, especially with colonoscopy. They would prefer a female to do their procedure.
Do you think that there might be something to do with the recent publications about mortality rates with female surgeons being better?
I don't know. I'll be very honest with you. I'm not aware of that. Maybe you could explain more what that showed, but...
it showed that female-led operating rooms.
Oh, that the patients have had better mortality.
Yes.
That doesn't surprise me.
Why?
Because I think women in general are just more conscious of the rules and paying attention to things such as pre-surgical checklists. Yeah.
Do you think
You are the smarter and stronger gender?
I think,
in my opinion.
Oh, we are making this as a separate podcast episode just for gender diversity.
I really believe that. I'm very serious.
Thank you.
Yeah. I don't feel ashamed by saying that. I think it's the real truth. So that does not surprise me.
So going very off the topic then from what we are supposed to talk about, but why do you think there is such resistance to female leadership? There's the saying of,
I don't know if it's
white boys club.
Yeah, there is some of that. I think that is changing to a certain extent. I think that also there are stressors on women that men don't have. What do I mean by that? A female physician is not oftentimes just a female physician. She can be a mother with children at home, and there are other responsibilities. And it may not be that they're not being allowed in, but they may not have the time to actually do those types of things to become into leadership positions. That may be a part of it. Is there still some of the old boys network? Yes, I agree. And things take time to change over time.
What you're saying is very promising for us.
I think so. I do. I mean, my generation is different than my father's generation, and I think my children's generation will be different than mine. So I think more and more men, the role of a man in the house is very different than what it was when my dad was there, right? And for me, and that's just, I think, the normal progression of the way of the world. At least I'd want to hope so.
Me too. But we did a podcast episode with Mariana Arvanitakis and Janine Van Hooft on females in GI. And what's evident that men are getting a bit more, let's say, insulted about the quotas and saying that females who are not qualified are getting the opportunities that they may not, that there's the reverse sexism going on.
There may be some of that sometimes, but I think also that may be the weak male ego that's speaking. But I'm not for equity without being based upon merit.
Meritocracy.
Exactly. Okay. So I think you need to take the better qualified individual, no matter who that is, and not give it to somebody just because of gender, race, ethnicity, religion, whatever. Okay. It should be based upon merit and accomplishments.
Okay, so it's not diversity for diversity, but meritocracy and maybe encouraging and giving opportunities to excel to that level.
Correct. And that can come from mentoring and more women who are in endoscopy who are becoming mentors to younger women or men. Okay. Mm-hmm. I had 2 female mentors long ago in my career, Dawn Provenzali from Duke University, who passed away a few years ago, unfortunately, and Linda Rabinek and both of them were mentors from afar. They had received types of grants for health outcomes research in the United States, and I was the 3rd person to get such a grant, and they were influential in my career. I had other mentors as well. You can have multiple mentors, but I had 2 female mentors, and I'm going back now 25 years ago. At that time, they were leaders. There's nothing wrong with that. You want to go, if you're going to seek a mentor, you want to find somebody, whether they're male, female, green, yellow, whatever color they are, who has the knowledge and who's able to mentor you and help your career go forward.
Do you think, this is off the script, but do you think that if you want to go far in the endoscopy, especially interventional, do you need a mentor?
Yes.
Or several? I
think we need a mentor no matter if you want to go forward in endoscopy or IBD or liver disease.
So it's a must if you want to go forward.
Absolutely. That's my personal belief. Yeah, absolutely. And unfortunately, today, there's more, or I should say there's maybe less people who are interested in academics, less people interested in research. And with that often comes that there are less mentors who are available to people.
Do you think that to go forward, you must be an academic?
No. I think it depends what you want to do with your career. I think if you want to be recognized for being a leader, usually up until now, the way that you get recognized is through your publications, right? That you're out there doing research, you're publishing the results that may hopefully are having an impact of how we're doing certain things or new technologies or new procedures. And then oftentimes you're recognized because you're a leader in that area of giving lectures and teaching, and your name gets out there. Today, one of the things that concerns me a little bit is that they're, through social media, I'm being quite controversial here, aren't I?
No, it's the right platform to be controversial.
There are probably a lot of people who are very well known through social media, but probably haven't written a paper in their life, or maybe a couple, and haven't really done any research at all, but they're considered leaders in their field.
Opinion leaders.
Opinion leaders. Exactly. Opinion leaders. Maybe not evidence-based leaders. So, and I think that can be problematic, to be honest with you. So I'm just sort of throwing it out there that that's the world we live in today.
But this is because we talk a lot about the impact of social media, and there's training in the sessions on how to do it well. But maybe we should be more critical about this.
I think we should be. And I think you need to take everything on social media, whether it's medicine related or not, with a big grain of salt. Okay. Because there's not necessarily checks of what goes into social media. And you can't always believe today what you see and read.
And you might be manufacturing your endoscopy views.
Absolutely.
The procedures.
Yeah, absolutely. And there's certain conflict of interest that all of us have, right? And those conflicts may be actually enabling what you're saying on social media, or impacting what you're saying, influencing what you're saying on social media.
Okay, so we'd never have to be blind about this, right?
Never.
Okay.
Maybe that's the cynic in me, but it's always good to have a little bit of cynicism.
Healthy skepticism.
Exactly. That's exactly right. Healthy skepticism. That's a better way of putting it.
Yeah. Thank you so much, Ian. We'll see you in ESGE days.
Absolutely. Barcelona, April 3rd to 5th, and our postgraduate course on Wednesday, the 2nd of April. See everybody there.
Yes. And we will do this once more in ESGE days. Then.
Fantastic. It's a date.
Thank you.
Thank you.